Before introducing Vlad Andelkovic, who I've just introduced, who's a medical oncologist based in Brisbane at the Princess Alexandra Hospital, which also covers Logan, and also with ICON at the Mater. Those of you who've been to workshops before know that we run this as a question and answer session, not a presentation. Although some of you who might know Vlad, he did our first virtual workshop in 2021 during the pandemic. So I might hand over to you, Vlad. Thanks.
Thank you, Mary. Well, thanks for inviting me here. Some of met last year at a virtual session, and it's good to see you in person this time. The way this is thought of, it was more as an interactive session, so I didn't prepare any presentation. If you have any questions or if there's anything that you wanted to discuss or that you didn't have time to discuss with your oncologists, please feel free to raise your hand and ask.
How do you, as an oncologist, decide what line of treatment you're going to put someone on when they're first diagnosed metastatically? How do you decide whether they're going to have chemo or not, or whether you're just going to put them on targeted therapy, or whether they're going to go on just hormone treatment or whatever? How do you work that one out?
Yeah, great question. There's a lot of factors that really play a role there. I mean, there's patient factors, there's a cancer factors, that depending how advanced disease is, what subtype of breast cancer, and what benefits we expect from the treatment, and what toxicities we're expecting. So obviously, ideally, we should choose the treatment that has no side effects, that has the best survival rates, and unfortunately, none of them is perfect. For women that have hormone receptor positive cancers, usually the first option is the hormonal treatment, just because it's less toxic, it doesn't come with a hair loss, it can provide quite good quality of life, and can keep the disease controlled for a fairly long time. If there's a HER2 positive breast cancer, then HER2 positive, HER2 targeted therapies are what we choose in the first and now in the later lines as well. In a situation where we don't have any of those markers positive, so in what we call triple negative breast cancer, the only option traditionally was chemotherapy, and then it's about again choosing which chemo is going to be best tolerated and most effective. And then of course patient preferences play a critical role as well. Some patients, knowing that they have incurable disease, will more prefer quality over quantity, so accepting that maybe some treatments are not going to be as effective, but they want to continue working, they want to continue traveling, then we choose maybe less toxic treatment, oral treatments, whereas some are really, their focus is longevity and getting the maximum time, and are willing to accept more toxic treatment potentially, but for the more benefit. And as I mentioned, the extent of the disease, sometimes we see people coming really unwell and sick, and then there's quite an urgency to start treatment to not to miss the window of opportunity. In those sort of situations, we choose whatever we think that may be best tolerated, or that is going to give us maximum chance of response, and then later on sort of we move to something that's more tolerable and can be used as a maintenance treatment.